Hi everybody, Dr. Seigler here, and today I wanted to discuss a question that I get asked rather commonly: is it Parkinson's? So now when we typically think of that disease progress, we think of this resting type of tremor, and that's actually one of the later stages of the disease. Now there are a couple other kinds that maybe look like Parkinson's, they're somewhat related, but they're maybe not actually. So there could also be maybe a progressive supranuclear palsy. That's usually a very aggressive type of Parkinsonian disorder. There could also be something called corticobasal degeneration, as well as multiple systems atrophy. But here we're going to talk about Parkinson's. Now, we typically think of that basal ganglia, and so if we look here at brain, in the top of the brain stem, we have this mesencephalon right in through here. Kind of the roof of the brainstem, but the floor of the rest of the brain. This is very important. This part of the brainstem actually contains the tyrosine hydroxylase cells in the substantia nigra that make the dopamine that feed, if we take off the top of this basal ganglia right in through here. Collectively, we might call it things like the internal capsule. It contains a lot of big words like putamen, substantia nigra, pars compacta reticularis, things like that. But if we look at the location of where this is, when we think of these collectively, what they do is they typically are in a good place to, like I say, do and don't. The basal ganglia can do things like have that movement, take that initial first step, blink, smile. It can also have a lot of those don't, or the brake pathway to some of the higher levels of the brain. So that way we don't want to have a tremor, or we don't want to have an outburst or something like that. Now, some of the things that we typically see initially are going to be a lot of like the frozen shoulder, or maybe someone will complain of constipation. Usually we'll have people do things where they can't, what's called dual task. So if we think of dual tasking, like walking and chewing gum, right? But what we'll do have is we'll have patients walk back and forth and, away from us and towards us. And then what we'll look for is to see if both of their arms are swinging. Because remember, a lot of the basal ganglia is that do swing your arms, do have a bowel movement every day. It's responsible for a lot of motor activity or movement. So if we have somebody walking back and forth towards us, maybe we'll have them start to do what's called dual tasking, where maybe we'll add a mental or cognitive function, where now somebody has to say every other day of the week, every other month of the year, start from 100 and count backwards by 7. But while they're doing something that they have to think about, we keep them walking. And some of the things that we'll notice is usually we'll see a reduced arm swing. The arm that was swinging is now kind of frozen to the side of their body or acting stiffer. Or maybe we'll see a lot of pauses, where now we'll either pause what we're saying and doing. So if we're saying every other day of the week and we're saying things like Monday, Wednesday, Friday, Sunday, Tuesday, Thursday, Saturday, if that Saturday maybe came when somebody was trying to turn and walk back towards you or away from you, there might either be a pause in what they're saying or a pause in what they're doing. They have to choose, what am I going to do? Am I going to turn or am I going to speak? Because the basal ganglia contributes to a lot of what are some kind of complexity. What can we do more than one thing at a time? And usually one of the beginning stages of Parkinson's actually is people have trouble maybe identifying certain colors or certain smells like peppermint or anise. So this can be very important because we know of how whenever we think again of the end stage of the disease process, things have been probably going on for a long time before that. And a lot of the times when somebody's coming to see us as we're getting towards the more end stage of that disease process, a lot of people might whisper something like, I'm not mad, because a lot of Parkinsonian patients, what we'll notice is kind of that mask-like face, and then they have trouble again with motor speaking well enough. So usually their voice starts to become a whisper and very soft. And that can be something as far as communication and facial expressions that can maybe be something that we can notice early on. Couple things that we can do to check for. It's called the glabellar tap. So typically if we tap someone, they're going to blink. It's hard to do it to yourself. It's like you can't tickle yourself, right? So if we like to tap, typically people will blink and then they'll stop. But sometimes we'll see people keep blinking and blinking and blinking. You can also look for the snout reflex. I might push right in through here. Look for the lips to move. We don't want that to happen. There can also be the palmomental reflex, which is where if we rub somebody's thenar eminence or right underneath their thumb, we might see the bottom lip kind of move from there too. There can also be the corneal reflex. That's not as fun. Some other things that we'll have people do is see, can you look up? Back to that mesencephalon, that controls a lot of these vertical eye movements, looking up and down. So looking up can be extremely difficult for somebody that's having that area of the brain affected. So instead of actually using their eyes to follow a target up, they might kind of actually just start to move their entire body to try to do the same thing. And again, we'll be looking for some facial expressions. So what we don't want to do is wait till the end stage of the disease process. It's very important that we identify it early on, as well as what's contributing to the loss of this area of the brain's function, so that way we can do what we can to slow down and stop this type of progression.